This program is brought to you by Emory University.
All right, good morning. We're going to go ahead and get started. And it is truly an honor this morning for me to introduce our grand round speaker. Professor Zlatko Fras is here. He's been a visiting professor with us here at Emory over the past month and has one more week with us. And many of you have had a chance to get to know him during his time here as well. He's the medical director of the Division of Medicine at the University Medical Center in Ljubljana, which is the capital of Slovenia. He's a professor of internal medicine and cardiology. He is president of the National Council of Specialties of Internal Medicine, chairman of the Slovenian National Program of Cardiovascular Prevention, and in 2017, he's an elected member of the Slovenian Medical Academy. He's the current president of the Slovenian Society of Cardiology. He's a leader in the European Society of Cardiology and the European Association of Cardiovascular Prevention, and he's authored almost 500 papers. But the most important thing I want to introduce Professor Zlatko Fras this morning is that he's truly become a member of our Emory family and an extended member of our family, the Sperling family here in Atlanta. And so with that, I'm going to introduce him here to talk to us about what's been going on in the country of Slovenia that he's been leading the charge on over the last number of decades. So thank you, Zlatko.
Thank you very much, Larry, for this nice introduction. Not only I would like to thank here publicly for your great hospitality and kindness, and I think it's not by chance, it's due to our quite long-lasting friendship, and I hope this will continue in the future. So, as Larry announced, I would like to share with you some of the data from our preventive cardiology programs. So I'll try to show the most important issues related to our nationwide primary prevention program, some flashes from the secondary prevention, included into the European perspective through the results of the EuroAspire studies. And then finally, I'll show you an idea or the path we tried to follow during the past few years, trying to integrate primary and secondary prevention activities at the level of cardiovascular rehabilitation and secondary prevention. So I have indeed nothing to disclose in connection with this presentation. And as I said, look, Larry, I'm so much grateful. We don't share only the professional interests, but also we can find something in common in our free time, which is not much, but I'm grateful really for your hospitality. But the main issue is that we share our interests in the field of preventive cardiology, and it's a nice cartoon saying most of the truth related to preventative medicine nowadays. So many clinical colleagues, and I can tell you I started with the true clinical cardiology, and I worked hard at the interventional part till nearly the year of 2000. But then I decided that maybe the true mission for me to fulfill is in preventative medicine and preventive cardiology. And it's not that preventive cardiology would take the business away. It's in fact so demanding time since population is aging and so many more patients we have at the cardiology department that it's worth to prevent more events. But in spite of this knowledge, not any one society I know around the globe invest enough into preventive cardiology and preventative medicine in global meaning. So these are the data from European Union, and it was published related to the call from the European medical organizations in 2010 that more healthcare resources should be allocated to the prevention. Not only because this is like steady low percentage, but also because even in Europe, like 10 years before, at the political level for the first time, it was declared through the European Heart Health Charter and in famous Valentine's Declaration from February 14th, 2000, that it's a right of every child being born in the new millennium to live until the age of at least 65 without suffering of avoidable cardiovascular disease. So it was an appeal and call for all of us really to prevent as many as possible premature cardiovascular deaths. And this I take as my personal, professional New Testament. So what I'm going to share with you. So first, some data on epidemiology and challenges we face in our small, tiny country in the center of Europe. Then, as I announced, some data from the National Program on Cardiovascular Disease Prevention, secondary prevention update, and finally, some thoughts on potential integration. But let me first start with the presentation of our country. So any one of you who doesn't know about Slovenia, where it lies, it's just in the center of Europe. You can see here at the western part, it borders to Italy, the northern part to Austria, eastern part to Hungary, and southern part to Croatia. This is not so unimportant in relation to what I am going to show you with regard to our situation on risk factors. So it's a small country, and factually, most of the world would say, okay, Slovenia, this is a communist country and Eastern European country. Factually, from political point of view, it is partly true, despite the communism in Yugoslavia was a bit different than in other countries. But we factually don't know. We say it is Central European positioned country, partly, I can say, Mediterranean, because it borders also to the Adriatic Sea. But anyway, not to be too long with my wording, I will show you just a short video, just to get the impression of our countries. It's very diverse. This is famous the border. And it's not meant to be, like tourist advertisement, but it's worth to think, to visit if you find time. If not for the other, there is one reason. So it's the only country in the world having love in its name. So anyway, now go to more serious business. So looking on the total health expenditure as a share of national GDP, you can see that in Slovenia we spent like an average of the OECD countries, much less than you spend in the United States, but I'll not go into these details. You know more about that. In absolute terms, we spent even less. So it's like, 2/3 of the OECD average, but if I compare this with US, we cannot reach you in a century or millennium, I don't know. But anyway, so these are the data on the life expectancy at birth versus total health expenditure per capita, and you can see that with life expectancy expectation, so we are quite comparable with some countries spending a lot more than we do, and we do relate this also to better preventive medicine in our country. Speaking on cardiovascular diseases, so cardiovascular diseases are still the most common cause of death in Slovenia, and the percentage is stable around 40%. So, and you can see that cancer is increasing, but now this relation during past 5 years, it's quite stable. Among cardiovascular diseases, as everywhere in the, I would say, developed part of the world, like 2/3 of them are due to atherosclerosis-related states. So putting Slovenia into a wider perspective, you can see that with this percentage, we are comparable to Central European part, even to Italy as a truly Mediterranean country. But we are doing much better than some of our Eastern counterparts. So now, comparing mortality due to cardiovascular disease to total health expenditure per capita, again, you can see that when we relate our spending on the cardiovascular care and total health care, it's much less than some of other more developed European countries, Germany, Switzerland, Luxembourg, but the epidemiological data are similar. What we are especially proud of is that already in 2009, we were in the small group of European countries, only 4 in Europe, Netherlands, Spain, France, and Slovenia, as well as Israel, as you know, close to Europe, were in this group, where the mortality due to cardiovascular diseases in men was not anymore the first cause. So the cancer actually prevailed in 2009. And we declared this as a, you know, interim or partial success of all our programs. We looked into the higher mortality in women. Why this is so? Because we just cannot believe that if we look back so that we will have such a great percentage in women due to cardiovascular disease. We didn't really find out yet what's the reason, but one of the potential reasons of this high percentage is due to not so accurate coding of the cause of the disease, since women die at higher age. So we have a lot of older women declared as having cardiovascular disease. And now putting in the time perspective, so during past 15 years, and this is also important in relation to our national prevention program, we followed like 50% drop in standardized death rate due to ischemic heart disease and stroke. And what we are especially proud of is that at the same time, premature mortality decreased significantly by nearly 40%. So we calculated this and put into the perspective of the well-known impact model, and we found that at least 700 lives are saved annually due to our primary prevention programs. Sometimes I compare this with the investment our country put into the building of the network of highways to reduce number of deaths in traffic accidents. And this investment is like 1/20th, so just 5% of the investments we did into our highways. So, and to finalize this part, so some data also on the prevalence. You can see that the prevalence is very comparable as in countries in Central and Western Europe. So it's up to 7-8% of atherosclerosis-related diseases. But I will not spend too much time on these details. What I would like to share is some other peculiarities. So this is a very small country. I showed it's 2 million population and area of only 20,000 square kilometers. So here you have the division on the regions. I can tell you that from this part to this part, it is only 200 kilometers. It's 130 miles. But you will see, this country is not only diverse on the nature, what I showed already in the video, but it's very diverse also in relation to age standardized mortality per region. So there is a huge difference from eastern to western part. So you can see here by 30% at the distance of 120 miles. And you can see this is like we have in Europe. But I would really like to find out or to explore more why this difference exists at such a low distance. And indeed, it's related to one of here mentioned factors or not, but we'll try to find out. We discussed also with the colleagues at the Global Health Department, together with Professor Sperling, Professor Ali, and Lobelo, and we'll put together probably a scientific project on that. But anyway, when we faced with this, disparities and this high rate of cardiovascular diseases, especially at the eastern part, we took this as an opportunity really to start with the program, which I'm going to show you now. So it's the nationwide program on primary CVD prevention, which is meant to target universally the whole adult population over 35 years of age. So factually, what we did, this happened nearly 20 years ago, but 17 indeed, is to not only to advise, but somehow to pressure all the stakeholders in the healthcare system and wider to participate in this program. So, and you will see that each of these stakeholders has its role into the program. You must be aware that we have different levels of prevention, and I would not like really to tutorize you, but still it's important to know what it means. Primary prevention is targeted to either total population, selected groups, or healthy individuals with specific causal or risk factors, while secondary and tertiary prevention deal with the prevention of repeated or recidivant events. And what we were aimed in 2002 was to establish a model which would integrate these different levels of prevention as much as possible. So, first, what we did, we looked on our resources, and these resources lie in different stakeholders. So we put together professional and scientific societies to play an advisory role. So like Slovenian Society of Cardiology, then Primary Care Network. Probably some of you know about this CINDI initiative. This was WHO program in 90s. Then patients organizations, non-governmental organizations, but also Ministry of Health. And we established a kind of a national forum on prevention of cardiovascular diseases, which still exists. So this forum has its meetings every February near to Valentine's Day, so related to Valentine's Declaration. And only having all these partners together, we actually were able to start to follow the triangle of involvement of different stakeholders into this comprehensive prevention. So having in frontline health services as where we belong, so as clinicians, also engaging the community and, of course, the politicians and political bodies, ministries, to introduce population health measures. And of course, our program also consists of several different aspects related to leadership. It has its strategy, but basis on partnership. So factually, we put together two basic approaches in prevention. So one is population approach by introduction of public health policies through legislation, funding, taxation, and the other individual high-risk approach on which I will spend a little bit more time. But first of all, so two major documents the government and the parliament introduced into our country was the National Health and Nutrition Policy. I think in the States you have a long tradition of this national or federal guidelines on nutrition, but we didn't, as well as the National Strategy on Health Enhancing Physical Activity. So these were two basic documents on which we based our program. But here is what I admire the most of our program. So we put as in parallel to that population measures, also the individual high-risk approach. So, as I said, this program is meant for adults from 35 years of age in men to 70 years of age in women. It's performed in primary care. So primary care, family doctors and GPs are involved. We have like 1,000 of GPs in our country. And the program was designed that in a feasible way. So we calculated what it means. So how many preventative visits every GP will have to do a year. So, and we came to a number of maximally 150 screening visits per year, which mean one screening visits every second day, which is not so much. And not only screening on risk factors, part of the program was intervention. So for all those declared as being at high risk, according to Framingham risk score, we actually introduced the lifestyle change intervention through health education measures. So these are group interventions in group of at least 10 patients at once, and I will show you the performance of the program. So here you have a scheme of the program. So of course, first step was screening and setting the priority of visits, because GPs were not able to do the whole their population in 1 year, but in 5 years, yes. So they set the priorities, and then this program actually started with the screening visits and then followed by interventions, and all this is registered into the registry of risk factors. And probably this is the slide on which I'm the most proud, what we performed in 16 years. So here, 1,100,000 screening visits in population of 2 million, which means that more than half of the whole population was screened in 15 years, and this is a truly valuable resource of data. So what we found on risk factors, nothing special. So here you can see the prevalences of smoking, physical inactivity, overweight, obesity. We looked also at one aspect which is not classical risk factor for cardiovascular disease, but it's important in our part of the world, so it's risky drinking. It's quite prevalent, so especially in men. And also on those risk factors we speak a lot, so high prevalence of hypercholesterolemia, hypertension, fasting glucose is high in nearly 1/5 of the population, so this is combined diabetics, but mostly people without diabetes. So really seemingly healthy. So altogether, 20% of our adult population can be declared as being at high risk. And now it comes the interesting part. So when we map these risk factors in different regions in Slovenia, we found that, for example, high prevalence of obesity is very concordant with the epidemiology situation I showed you on standardized mortality and cardiovascular disease mortality. As well as hypercholesterolemia corresponds to those regions where we found higher mortality. So we started to study that, but still we didn't elucidate the reasons, so that's why this is part of the mission to find maybe a connection and ways and find tools on how to investigate this better. For sure, part of the answer is in social inequalities, because here you can see, so darker color means less income. But also it has connection with our neighbors and the culture, like Hungary, you know, on the east, so more continental nutrition, and Italy on the west, Mediterranean, or different, I would say, lifestyle. And as Larry said on Friday, so diet, it is not only what you eat, but it's your lifestyle. So that's why I think here is the clue. So altogether, now when we found patients being at high risk, they were sent, and they are still sent into the workshops. So here you can see we have two types of workshops. So this group advice, at least 10 in a group. So basic workshops 3 times 1.5 hours, and intensive, like 2 months of 1 hour to 2 hours of advice. Also, we introduce individual counseling. And what is the performance? So again, in 16 years, here are the numbers. Number of workshops. You can see. So altogether, in 16 years, nearly 60,000 workshops were performed, and more than 500,000 of participants were included. If we go into details, this is not that this will be like uniform participant, because some of these participants went to more of these workshops. But our estimation is that more than 300,000 people, individuals, were involved. So why is this big here? Because we realized that quite important risk factor is stress, and that's why GPs demanded to introduce the workshops on relaxation techniques. So to summarize, in 16 years, more than 1,200,000 screening visits, and more than 500,000 of people being advised on lifestyle change. So this is on adults. When we went through this presentation with Larry last week, he asked me whether we do something in children. Yes, we do. So already 25 years ago, we introduced a program on healthy schools. This is in Slovenia. Zdrava šola means healthy school. And it deals with many different aspects, with physical activity, with the nutrition, not only in small children, but also in adolescents. So recently we introduced also a website where both children and adolescents can find information on healthy lifestyle. So what is the performance? So in the first and second round, so in 90s and first decade of new millennium, 130 schools were involved with different activities. But I just found last week, this I even was not aware, that until 2019, it's 25 years of this program now, 400 schools around Slovenia were included into this program. And indeed, it's not without the effect. But anyway, we have to ask ourselves whether this is effective. So besides such individual proofs, we also did some interim analysis on different risk factors. Like here, you have the effect of lifestyle change on total cholesterol. It's not so much, but still significant. On the other hand, we were not so successful in pre-diabetes and diabetes-related risk factors. Like you can see, some of the indicators worsened. So speaking about children, you can see if you look at the overweight of youth in OECD countries, Slovenia is not doing very good altogether, but it's somewhere in the average. But what is important is that if we look at obesity among children aged 7 to 8 years, we are not so bad. And I can say that it's my belief that this is due to this program of healthy schools, that factually in 10 years' time, obesity among children decreased due to this program. So now the second one is secondary prevention. Here I will be a bit more quick. So I'll show you some of the results from EuroAspire, as well as one recent national survey on post-myocardial infarction quality of care. I do believe that prevention and intervention can go hand in hand and do not exclude each other. And it was shown also in EuroAspire. So I will not go into details on how many of different patients were involved into these studies, but just for you to know, so these are cross-sectional studies which follow every issue of the new European guidelines on cardiovascular prevention. And these surveys deal with secondary prevention. So it's like a screenshot in coronary patients, either being after PCI or CABG, minimally 6 months and maximally 2 years after the event or the intervention. So, and this study started already in 1995, and the last one was conducted from 2016 to 18. In the last 3 editions of EuroAspire surveys, also primary care arm was added, so targeted on patients at high cardiovascular risk. But I will share with you only the data on secondary prevention from EuroAspire 5. And here I will show you data on our coronary patients from Slovenia. So if we look on prevalence of smoking in different European countries, as it's shown by EuroAspire, so in coronary patients, we do quite well in relation to persistent smoking in coronary patients. Not so well, but still, I would say moderately well with regular physical activity. But what's really concerning is prevalence of obesity among our patients, as well as prevalence of central obesity. So it means that our population is really comparable to populations at the western part, since obesity, prediabetes, and potentially diabetes is what we really are afraid of. So looking at the therapeutic control of hypertension, so overall 50% of people in Europe somehow is at the recommended levels. This is comparable to United States data. Just recently we had a conference on hypertension organized by CDC. And LDL cholesterol is, at least in Slovenia, is quite well treated compared to other countries. But as I will show you a little bit later, it's a question whether this can be somehow used as a representative figure for the whole country. Because these are data from single center. This is from the University Medical Center in Ljubljana, and it could be that the average in the country is not as it's shown here. So we use high-intensity therapy in our patients quite frequently. So in accordance with the guidelines, I can say. But as I mentioned, so the problem which we foresee is diabetes. And here are the data on the distribution of glycemia categories. And if you look, so normal glycemia, impaired fasting glycemia, undiagnosed diabetes, and non-diabetes. So if you put this all together, we diagnose diabetes in this survey by doing OGTT. 45% of our patients are diabetics. And if you add 27% with impaired fasting glycemia, you can see that almost 3/4 of our coronary patients have dysglycemia. And this is a true warning for us. And now, just 3 slides on our recent survey on quality of care after myocardial infarction. These are data for 13 different Slovenian hospitals. And these are data just on mortality, 30 days mortality and in-hospital mortality. And you can see great differences. So that's why we can somehow put also those data from EuroAspire under question, whether this is really representative, because you see it's quite big difference. Also, when we look on quality of secondary prevention, and there are significant differences in use of different components of secondary prevention therapies. Of course, we did many different analyses on the influence of hospital volume, PCI access, and quality of care. I don't have time to go into details, but what's interesting to share and what's maybe new, we did Kaplan-Meier survival estimates related to either the use or non-use of PCI, so revascularization, and their use or not use of statins. And here you can see not only that the survival in patients not using statins is less than in those not being revascularized, but also that this difference between the two groups is greater in the statin analysis. So if we put all this together, so we can explain only up to 20% of the variability by patient's characteristics. By hospital characteristics, we can take into account, as I said, the volume and access to PCI. Access to PCI indeed predicts shorter length of stay, but volume as such predicts better secondary prevention. So that's why the data from our center are a bit better than from other hospitals. So how is secondary prevention and rehabilitation organized in our country? So we have a network of outpatient rehabilitation centers, which are coordinated by a national center located at our institution. And the cornerstone indeed is outpatient now. You know about the tradition in some Central European countries, Germany, Czech Republic, Austria, of the inpatient stationary rehabilitation. but we abandoned that. We still have 2 spas where they perform that for those patients who are not mobile and have maybe worse health status, but we focus on outpatient rehabilitation. Now, and finally, I'll share with you the model of potential integration, what we do. So if we take this network of secondary prevention and rehabilitation centers together with the network of health promotion centers dealing with lifestyle change advice within the primary prevention program. So it's obvious that we do have a strong basis to speak about the potential of integrated CVD prevention. So I personally do believe that we can be more effective and more efficient by doing so. Why? Because I think we should really focus on the patient and not only declare this, that the patient is in the center, but to organize the healthcare in a way that the patient is truly in the center. So here we involve, as I said, family general practices together with centers of health promotion, dealing with behavioral risk factors management, raising awareness, putting pressure on patients to be more physically active. And on the other hand, our clinical preventive cardiology units, which base on outpatient rehabilitation programs. I do believe really firmly that without the involvement of patients themselves for long-term self-care, we are not going to be successful. And that's why we involved also patients organized in so-called coronary clubs. And in our model, we do foresee the potential ways on how to connect this all together. And this scheme of the potential patient's pathway is here. So, as I said, in primary prevention, GPs and family doctors refer patients to centers of health promotion for lifestyle change. On the other hand, preventive cardiology units, we have to be in closer collaboration with the GPs and family doctors. But on the other hand, we have to have the access and the right to send patients directly or refer patients directly to centers of health promotion. Because why to organize these activities of health promotion and secondary prevention at 2 different places? So then, of course, patients' organizations should be included, but here we have a problem since it depends all of the patients' contributions. What we would like to introduce is that our insurance institutions will recognize this as valuable and to introduce the voucher system to participate in this long-term self-care of population. In addition, I think we should invest more and we should do more on patient empowerment itself. So it's out of what I said about the long-term self-management and to improve the situation related to health literacy. And only with this, I think we can better manage cardiovascular diseases itself. And speaking about patient empowerment, it's all about communication and education. That's why it's so important to integrate these 2 levels, both health promotion centers and the secondary prevention outpatient rehabilitation units. So I come nearly to finish. So I think we face truly the true shift from evidence-based medicine, which we live for 20, 30 years now, into more personalized medicine. I don't mean with this only genetic issues pharmacogenomics, pharmacogenetics, but personalized in a way that the patient should be in a center, as well as the need for a shift from volume-based medicine to value-based medicine. I know that you speak a lot on that here in States. We had a so nice lecture at the meeting mentioned with the CDC on hypertension. It's a true challenge, but it's a true challenge also in relation to what we listened on Friday here. No, last time I think it was on the physicians burnout. So it's not the case, or it's not the answer in increasing the volume, but it's the answer in increasing the value. So this is the true future: personalized and value-based medicine. And now I will finish. I will put all together to try to summarize with some personal viewpoints on cardiovascular disease prevention. Probably this is one potential of improving CVD prevention paradigm. But here are the components. So first of all, I think that when we speak about primary prevention, we should always have in mind that we have to deal with the increasing quality of life of our patients. It's not to restrict or restrain patients from those activities they enjoy, either what they enjoy to eat or do in their free time, but we should deal with each individual patient personally to improve his quality of life. The second thought is that CVD prevention should be comprehensive. It's not just like, when we have a patient at the rehabilitation unit and we focus on exercise. So we should deal with all the aspects of his risk. So that's why it's so important to advise him about the lifestyle, other components of lifestyle. Then, as I said, without engaging and empower patients to do truly long-term, lifelong self-care, we are not going to be more successful as we are. So our percentages are low and will stay low without this. And not only that we deal with cardiovascular prevention, but C&D goes for chronic non-communicable diseases. We know about the crossing paths of atherosclerosis and cancer, but we should use this more and even more effectively, so with different disciplines. So I would like to thank you. I was a bit long of 5 minutes, but hopefully I'm still in time for questions.
Yeah, so first I want to say what a fantastic presentation. Thank you for sharing all the great work that's being done in your country. And we have a lot to learn from Slovenia. And if you think about the work that's being done there, I mean, you could imagine if we did that on the scale of our country, but let's even just say, what if we could do that at Emory Healthcare in terms of an initiative? And in this country, there's a true crisis going on, that the cardiovascular mortality rates over the last number of decades that we celebrated have flattened out, and now there's an uptick. And this is a true emerging re-epidemic of cardiovascular disease occurring more in young people in our country. And I think we've become somewhat complacent about this. And so I don't know if you had some advice to us, Zlatko. I'm not going to say to the United States, but just how about just to Emory Healthcare, because you're starting to get to understand our organization and the complexities in the different hospitals. So how would we get started in a partnership like you created in Slovenia?
So as I said, look, you do great things, and I'm really only grateful to have the opportunity to tackle with some of them. So what we don't have and what I'll take with me is we don't have research at all. If we have some, but what you do is really great, and I'll try to establish some connections in this part. But as you saw, we are maybe more practically oriented, and this program was, as a matter of fact, program of enthusiasts. And I can tell you that without the political support, this I shared with Larry already at the time when we had the opportunity to introduce this nationwide universally accessible screening program with the intervention in lifestyle. The minister was my former mentor, preventive cardiologist, who factually believed in that, and it's the belief, it's the passion which has to be present. So despite it seems like impossible to do something like that, and you'll remember that maybe you heard at medical conferences, it's said several times, but it's just like a quote or a nice wording, that in old China, ancient China, you know that physicians were paid in accordance with what the percentage or what the share of their population was healthy. So a physician whose population was fully healthy got the full reimbursement. If there were sick patients, so this went down. We are just on the opposite side. So we pay for more sick in your population. So this is not right. And I believe that systems like Emory, I have to admit I don't know anything, but maybe something. But the system like Emory is, so it's a comprehensive, great system. Such a system by itself can change the paradigm. And this is a true challenge. At least if I can answer to Larry's, I won't say provocative question, but this is the true challenge. So not to abandon other activities. You are so great in clinical medicine, in research especially, but really try to focus on this, how to change what's really painful here, maybe. So that great percentages, great spending of resources which can be spent better. So why not university having more than insurance? But this is my personal perspective, so don't take this as any offensive position.
Other questions or comments? Maybe Candy? You have the...
So I think Fulton County has about 1 million population in Atlanta. DeKalb County has about 800,000. One question is whether you think that you have an advantage based upon your population. I know your largest city is about 280,000 or something like that. But as we look at things in the United States, should this focus be more on a local county level, getting into the school systems, that type of thing? Personally, I have difficulty seeing making a big impact on a healthcare, whether it be Piedmont Healthcare, Emory Healthcare, whatever, as far as the major impact, particularly in this childhood thing. And I know a few years ago we were seeing a lot of ads out of children's healthcare that was really ads on TV that obesity is not cute, focusing on things. It's very controversial ads. I don't know what came out of that, but just comments on where the responsibility or focus should be. Of course, in our country, all you hear from the politicians is about healthcare being a right or debates around that, rather than a lot of mention to the population of healthcare as a responsibility of individuals as well. So.
Yeah, so thank you for the question and the comments. Indeed, our biggest city is 250,000 people, and it's not comparable to Atlanta at all. And the whole country, and this is a true advantage, we not only that we nearly see from one side of the country to the other, but factually we know each other well. So we can look at the GP's office from my office. So this is not comparable. And we tried to use this advantage for the best of this program. But anyway, I think you surely have maybe even better ways to do so. I saw, as an example, a great program Professor Fuster introduced in New York, and something like that, or maybe even better, if you improve it, you can surely do in at least one county. Then in the another, maybe it would be great to somehow motivate the local community. If you have a county where the people are more involved into this community work, just to say to show a primer. So we can do, I don't know, for 20,000 people, such of a program. Even I feel maybe more feasible here, because what I learned and what we don't use in Europe at all are, you know, donations from people who have a lot of money. So why not to attract somebody with, he or she will even not notice, to invest, I don't know, a few millions of dollars in such a program, and showing what the impact it can have. There are several models developed in Europe. One is ours. So we have this elaborated very well in these 15 years of these workshops, but the other, which was published and somehow trademarked, is the program Euro Action, which was developed by the group of Professor Wood in London, and which will now continue in one big project in Ireland, led by the National Patients Organizations, CROA. So there are ways, and I think it's just a need of somebody to take a bit more of care and to engage few enthusiasts. That's my suggestion. Maybe it can be a kind of an investment from the university to have, you have so many people from around the world, so great people who can take this as a true challenge, and then it will go. I think, look, it's a feeling. I feel so good here because I feel accepted. Nobody to whom Larry introduced me was not kind. So this you have. I can tell you, I've never seen such a community. So that's you have, and use this.
And then maybe one or two more questions. Arshad, do you have a question or a comment?
Thank you very much. I had two questions. One was this east-west disparity that you described in Slovenia. When you did this implementation of primary care initiatives and so on, did you find a difference in what was happening in the two areas, as it were? And was there any titration of how you were delivering it to a community
Yes.
that was perhaps socially different from the other?
Yes, look, contrary to our expectations, the response from the population in the eastern part was better than in the western part. And this is related to their lifestyle itself. So they are more reactive, so to say. They reacted better. So they were more responded to invitations to workshops, and we even did special programs because we were aware of these disparities in certain smaller communities there. Like, I remember one program which was there for 1 year, so 1 year intervention in a village of 4,000 village, okay, small town of 4,000 people. And we followed the improvement of several risk factors and lifestyle indicators just in this 1 year. Anyway, I think that it's a long-term project. And the results of this intervention, which we do both at the level of school children and then adults, will be visible, you know, in 15 years, something is visible, but maybe in 20, 30 years. So, yes, first, we put more attention to that, and second, this population was more reactive than the less endangered. But this is due to lifestyle. You know, Mediterranean, so people at the Mediterranean part, they're just relaxed. They don't care so much. And maybe here is the answer. I don't know.
There's one other question.
Maybe, go ahead, Arshad.
You said that the diabetes and dysglycemia incidence was like 75%, which is
Yes.
huge. So it cannot all be due to obesity, because unless there are 75% people who are overweight or obese. So there's this whole syndrome of thin and obese, thin and diabetic populations, particularly in the non-Western populations. That is an increasing number, and that's why cardiovascular disease is also very prevalent. And the pathophysiology of these people is a little different from insulin resistance, it's thought. So do you have that kind of population also? And is
Yeah, indeed we have, and this was just one aspect I just pointed to and related these two, so central obesity, so metabolic syndrome, prediabetes and diabetes. Of course, we do have, so when we discuss also with our diabetologists, they expose this fact that it's not everything in obesity. Also, as I said, it's the one center, it's university center, and I shared a very interesting comment of one of our Norwegian colleagues at the Europrevent just last year, when I somehow commented the fact and our concern about the diabetic risk. He said at the end of my presentation, he said, don't be so much frustrated with that. We found the same figures in our center, and then when we deeply analyzed that, it was shown that it's normal and it's the consequence of so good prevention for the rest. So we now have to focus and to find out what's different with these people with diabetes and dysglycemia, since those patients without this risk don't have so many events more. So it means that actually we did a lot in those without these risk factors, but now we have to focus on them. So it's not only bad, but as you said, we have to explore.
We thank you again. Dr. Fras will be meeting with some faculty and fellows today, and this is not the end of a relationship. This is the beginning of a long-term Emory relationship with your colleagues in Slovenia. So thank you again, Zlatko. Wonderful.
The preceding program is copyrighted by Emory University.